principal investigator in a UO1 grant that focuses on improving access to cervical cancer screening in Nigeria. And so without much ado, I'm going to welcome Dr. Greg to take over and begin his lecture. Thank you so much, Greg.
Well, thank you. It's nice to be here. I've been here for most of the week on these presentations, and I always learn something on these talks, and so it's great to be here. And so today we're going to be talking about EPIS, and so I look forward to your questions as well as we go through the day. EPIS, Exploration, Preparation, Implementation, Sustainment Framework, was really meant to be user-friendly and to help not only the researchers, but also the people that we work with in thinking about and framing implementation projects. So we'll go through and look forward to your questions. First, I want to acknowledge where my funding has come from and the support we've had from the National Cancer Institute, the National Institute of Mental Health, National Institute on Drug Abuse, the Fogarty International Center, National Institute of Child Health and Human Development, the CDC, and the WT Grant Foundation. And in the projects that I've worked on there, we have used the EPIS framework in the US, in Sub-Saharan Africa, in Mexico, and also in Europe in different projects. So it's very flexible in terms of how we use it. And also Dr. Michael Herbert and Dr. Sally Horwitz, who were co-developers of the original EPIS framework, and then other collaborators who I have worked with over the years using EPIS and kind of advancing EPIS. And I think you'll see as we go forward that EPIS is quite adaptable, and we'll be talking about that as well, how it can be adapted for use. So I'm going to talk a little bit about the origins of EPIS, and then how it developed based on a systematic review that we did recently, but also how EPIS has been adapted and applied in large-scale trials, so that you can just get a sense of some examples. And I'll ask Dr. Onyeke to let me know if there are any burning questions that we need to address as we go, because I can't see the Q&A as we're moving through. So, there are many frameworks. I think you've been getting a sense of REAIM and CIFR, and today EPIS. And even in the talks and the other frameworks, we often talk about combining frameworks, bringing them together. And so, this article by Dr. Tabak, Kung, Chambers, and Brownson really was the first to take stock, look at the different frameworks and think about, how they can be useful and how they might be used in both research and practice. So lots of choices out there for you to consider, but it's great to be here to talk about EPIS today. And when we talk about the types of frameworks, Dr. Per Nilsson from Sweden published this nice article back in 2015, making sense of implementation theories, models, and frameworks, that talks about the types of frameworks and how they might be useful in different settings. So this is a great paper to just take a look at, to get a sense of the landscape of different theories, models, and frameworks in implementation science. But it begs the question of, when we think about EPIS, just what type of framework is EPIS? I think in our talk yesterday, talked about CIFR being a determinant framework. For EPIS, does it have process characteristics, and does it have determinant characteristics? Well, really, EPIS is both. It's a process framework in that it lays out the phases of implementation. So it helps us as researchers, and it helps our partners and collaborators to think about moving through the implementation process. And it's also a determinant framework. determinants, meaning what are the barriers and facilitators and mechanisms in implementation. And when I say mechanisms, I mean, what are the things that are mediators or moderators of effects? And so when we talk about having an implementation strategy to affect a barrier or a determinant, you can change the barrier, but there may be other things along the causal pathway to consider, those mechanisms, mediators and moderators, that may affect how implementation goes. And we'll be talking a little bit more about that throughout this presentation. So I wanted to point out that there's a website for the EPIS framework. So at episframework.com, and it has a number of resources. It has descriptions of the EPIS framework, of the determinants, of the process characteristics. There are also archived webinars describing EPIS and how to use EPIS. There are publications that you can look at or download or link to that describe how EPIS has been used in various projects and studies. And there are also measures that are there to assess some of the EPIS determinants. And that's always in development. So we're always adding measures and tools to support the EPIS framework and using the EPIS framework. And there are things like checklists and guides for using EPIS. And we're putting up qualitative interview guides to assess different constructs in EPIS as well. So just some nice tools and resources there. And maybe if we have time, we can go back and look at that framework. But so as I mentioned, EPIS is both process and determinant framework. The phases help us in planning, in anticipating potential challenges, and in getting to sustainment, right? And the goal, I'll probably say it multiple times, but the goal of implementation for me, it's really about sustaining effective evidence-based practices and approaches to improve health and improve public health and individual health. So let's be thinking about from the beginning, how do we get to sustaining these in different settings? EPIS frames the implementation determinants and mechanisms across what we call outer context, which is larger system context. It could be a country, it could be a province or a county, but it could have its own policies and issues that affect what we call inner contexts of organizations or clinics or settings where services are provided. So we look at determinants and mechanisms across outer and inner contexts within each phase and across phases. And another thing for EPIS is that it enumerates or identifies those common and unique determinants and mechanisms across levels and phases. And finally, it allows for recursive process. And what do I mean by that? A recursive process is really one where we may identify issues to address in the exploration phase. We may prepare in the preparation phase to implement. We may start implementing and then realize, oh, we have to adapt, we have to change, which takes us a little bit back to the preparation phase. So it allows going back to earlier phases to sort of catch up with the things that are affecting an implementation process. So the original from the 2011 article that we first published, we identified these different constructs within EPIS. This idea of outer context, so what's in the service environment, and that, as I mentioned, can be policies, it can be a jurisdiction that affects what types of innovations, what types of practices are used and utilized during implementation. It identifies this idea of interorganizational environment. So say you're going to be implementing in 2 or 3 clinics, what's the relationship of those clinics with each other and with policy and policymakers in the outer context. And importantly, in the outer context, we want to really understand population health issues. So what are the needs of patients, of clients, consumers in terms of the diseases or health problems that you want to identify and address? What's the prevalence in the different setting? And can you make a case for why it's important to do implementation in that setting to address health on a larger level? If we move over to the inner context, we're really thinking about what's happening within a given organization, a clinic, a congregation, a church, it could be wherever you're actually implementing. And what are those intra-organizational characteristics? For example, what's the leadership like? Is there a positive climate for the use of the innovation or the practice that you want to implement? And within those organizations, thinking also about the structures and processes. So for example, is there an electronic health record? If there are paper records kept, are those well organized? Can they be accessed? Can they be used to support care and support treatment? And then also within the inner context is the individual adopter characteristics. And this could be the healthcare leaders at a hospital or clinic. It could be the direct service providers, the doctors, nurses, community health workers that would be adopting and using an innovation or an evidence-based intervention. And we'll get more into detail on this as we go. But even within the inner context, there are levels. There's the organization level large. Within the organization, there may be levels of management. There may be a hierarchy of influence that you would consider in having leaders buy in and support their teams in providing care, for example. So we can have many things to talk about in the inner context as well. And then originally we had this idea of interconnections, interactions, linkages, and relationships, because even within these large, complex implementation projects, there are relationships, and they can be between organizations. They could be across organizations in the outer context, inner context, or relationships of people who are important in the implementation process. For example, a champion at a Ministry of Health, for example, could be have relationships with people in the inner context who run clinics, who run hospitals. So what are those relationships like, and do they really support the use of evidence-based practice? And then we have the idea of the innovation characteristics. So what is the thing, as Jeff Curran would call it, that's being implemented? And how well does it fit at the system level, outer context, and how well does it fit at the organization level? So the reason I have intervention developers noted here, and we have that in the early EPIS framework, is that you may have heard the phrase designing for dissemination. So there are many frameworks that encourage clinical intervention developers to be thinking about implementation from the very beginning, from the very get-go, so that they are not creating something that can't be implemented. So I'm going to move quickly. The other thing that I think was really useful in the original EPIS framework, the way we did it, is we listed the phases, and then we identified a number of factors in each phase: exploration, preparation, implementation, sustainment, a number of determinants that could be important in implementation, both in the outer context, so socio-political context, the funding, advocacy, those interorganizational networks that could be important in implementation, and in the inner context. So the organizational characteristics, knowledge, readiness for change, receptive context, culture, climate, leadership, et cetera. And as you can see, these aren't identical across all phases, but there are a number of factors that we believed to be important across the different phases. And so, as you're engaging and collaborating in identifying issues in exploration phase, it's important to consider who's at the table and how that moves forward in preparation, implementation, and sustainment phases. So in the exploration phase, again, as I said, we want to begin with the sustainment as the goal. We want to engage partners in a multi-level assessment of what's needed, what's the public health issue, what's the health problem that we want to address, and what are the potential solutions. And when I say multi-level, really thinking across levels, outer context system, the inner context organizations, provider, patients, and client population. We identify and understand the health problem, identify the potential innovations or clinical interventions, evidence-based practices to treat or address a public health problem. We're really trying to understand that multi-level context, the policy, funding, and service infrastructure, so that we can identify the determinants and mechanisms. And this is, I call this initial identification. We want to be as comprehensive as we can in understanding determinants and mechanisms, meaning barriers and facilitators, but also be ready through the implementation process for issues, problems that may emerge. So I also want to highlight the values of equity, diversity, and inclusion. And EPIS considers the interactive nature of clinical care and public health interventions that patients, clients, consumers, there's no perfect term, but aren't passive recipients, but active participants and partners in care. And so we want to recognize that throughout the implementation process, the value of equity and inclusion, collaboration, shared decision-making in the implementation process. In the preparation phase, we're really engaging partners in considering what determinants and mechanisms are the most important to address, and at what levels. For example, in the outer context, at ministries of health, in the health service system, do we want to address opinion leaders? Do we want to focus on the provider organization, clinic leaders, clinic providers? So at what levels are those determinants and mechanisms most important? So again, the goal is to collaboratively identify and or develop implementation strategies to address determinants and mechanisms. And then we want to engage our partners in identifying what strategies might be most helpful or most effective in implementation. So, we may identify 3 barriers that we want to address, and then identifying a few strategies. But it's important early on in the preparation phase to identify the strategies we think are going to be most effective in addressing the specific problem. And those strategies can be multifaceted or can be single strategies. So they could be things as simple as, supporting a champion will try to create enthusiasm for a new innovation. But I have to say, in my experience, usually multiple strategies are needed because there will be more than just one barrier. So important to think about what multiple strategies might be used. And then determine the roles of partners in the project. Of implementers, intervention developers may be involved in adaptation of an innovation, of an evidence-based practice, but also, what's the structure going to be? Who's going to be involved in the implementation? Would it be coordinators at your given sites? Would it be the doctors or physicians at those sites, nurses, community health workers, or support staff? Information technology folks may be also important. So thinking broadly about who's involved in the preparation phase and how they can help with the implementation effort is critical. In the implementation phase, this is where actual implementation begins. So we're training staff, we're engaging with patients or clients, we're providing services. It's really critical, and often we don't give enough thought to how we assess implementation strategy fidelity. So often when we talk about fidelity, we first think about clinical intervention fidelity. So if the goal is antiretroviral treatment, for example, we may want to know if a prescription was given, if a prescription was filled, if the patient is taking the medication. So that's innovation or intervention fidelity. For implementation strategy, for example, if our goal is to improve leadership, to improve the climate of the organization for the use of the clinical innovation, then we want to assess how well the leadership, training, leadership development occurred, for example. So we'd want to know the steps in that implementation strategy, and was it done according to how we have laid it out. Also important in the implementation phase is to identify and track potential adaptations. And we could do a whole talk on adaptations, but it's important to note that often adaptations can be planned, but often occur as things might have been tailored or adjusted for a given setting. So there are some ways to identify and track adaptations, and there are resources for doing that. Our colleagues, Erin Finley and Allison Hamilton, for example, in the US, identified what they call an approach called periodic reflections, where you would bring the team together on a quarterly basis and reflect on what's been happening at different sites during an implementation and how have things been adapted or changed, or maybe they haven't been, which would be great, but you can catalog those adaptations so you can talk about how they fit. And then there's methods for really thinking about how the nature of those adaptations, and we can talk about that later as well. And finally, in the sustainment phase, what we really want is to understand how well a practice or a new innovation has been institutionalized. And often the way to do this is through a mixed methods assessment using qualitative and quantitative methods at multiple levels. So for example, in the inner context at the provider level, we developed the provider report of sustainment measure. That's a three-question measure of sustainment that can be utilized to understand the perceptions of providers about how well and how much the innovation is being used. At the organizational level, we may want to look at structures and processes that are active and in place that support the ongoing use of the innovation. That's that institutionalization. And in the outer context, are there policies, are there system level actions that actually support the sustainment and use of that innovation? And in fact, are those in place and supporting that? And then we're going to talk a little bit when I go through the model in more detail about funding and contracting and bridging factors that link outer and inner context. And again, important to understand the innovation that's being implemented, and is it being used with fidelity, and are we getting the outcomes of the innovation or the evidence-based practice that we wanted? So it's a lot of background. In 2019, we conducted a systematic review of EPIS led by Joanna Mullen and our colleagues. And we looked at where EPIS had been utilized, and we identified 11 countries, multiple different public sectors where it had been used, and physical settings, including health clinics, schools, child welfare agencies, substance use disorder treatment, community-based organizations in that review. And the sort of revamped EPIS framework took us some steps further in the broader constructs within outer context, a little more detail of the broader constructs in inner contexts, going a little further with innovation factors, keeping this idea of interconnections, interactions, linkages, and relationships operating within and across levels. And what also emerged, excuse me, was this idea of community academic partnerships, purveyors, intermediaries, policies, and funding, what we call bridging factors that link outer context and inner context. And this is consistent with our interest in policy dissemination and implementation research, and raises the question of how we get from outer context leadership policies, et cetera, how we get from policies to actual practice. And the way we think about that in EPIS is through these bridging factors. So for example, if a policy is set in the outer context, how does it get translated into actual use of an innovation or practice in the inner context? So we're thinking a lot about that in terms of not only identifying bridging factors, but understanding how to influence policy most effectively to have an impact on inner context delivery of and use of evidence-based innovations and practices. So again, the outer context, the sort of larger dimensions are leadership, the service environment, funding, and contracting, which sort of fits in those bridging factors as well. The inter-organizational environment networks, again, the patient and client characteristics and advocacy, which were present in the original EPIS. And so this is a further development. In the inner context, we say a little bit more about kind of the multi-level nature and including leadership. And I do want to point out that even in outer context, we have leadership pretty ascendant, pretty high up, because often leaders are influencing things like policies or impacting policies. And in the organization, organizational leaders are working with their teams and often making decisions that affect organizational characteristics like the culture and climate of the organization, quality and fidelity, monitoring, support, staffing, and also the nature of individual providers, who is hired, who is supported in that implementation process within the inner context. So everything is like related across all of these different constructs within EPIS. For the innovation factors, again, we're thinking about that innovation fit at the system, organization, provider, patient, and client level. And we have that first, right? It's really how well is it going to fit? If we select a practice that's just going to be a non-starter, is not going to be a fit with the processes or the funding or support in the service system, then it's going to be very difficult, if not impossible, to implement. And so again, we have the contributions of the innovation of the practice clinical treatment developers in thinking about the innovation characteristics and how they can be most implementable. And this idea, again, of bridging factors, which has now, even since the systematic review has expanded, a lot of people are doing work in this area of how to bridge policy and practice. So again, the interconnections and linkages and relationships didn't go away. We've replaced them here, but they're also related to bridging factors and across the outer and inner contexts as we go. And our colleague, Rebecca Langnick-Hall, has done a lot of work in thinking about bridging factors, these dynamic links between outer and inner contexts. And so there's a growing literature. So I encourage you all to take a look at some of that and think about how it might apply to the work that you're doing. So one, I think, really strength of EPIS is that EPIS users have been adapting for given projects and for given settings. And I want to stress that I think with almost any framework, you're not going to necessarily use every determinant, every construct within a framework. It's really up to you to think about what aspects of a framework are most useful for you and your collaborators, and think about whether adaptation needs to occur. And it's, I think, needed for most frameworks and for most projects. Here's an example of EPIS that was adapted for child and adolescent mental health. And this adaptation was based on a systematic review of the literature of published studies that looked at dissemination and implementation in child and adolescent mental health. And then the constructs in outer context and inner context across the EPIS phases were identified. So these were things that were looked at empirically in articles included in the systematic review. And it helps winnow down or to narrow the focus of what determinants and mechanisms you might want to look at as you go forward. So, conducting a literature review can be a really good way to think about, what factors across phases are going to be important in your project. And so you would look, for example, if you're in cancer control, looking out what determinants may be important in implementing something like cervical cancer screening and treatment. And that's a way to narrow and adapt the framework to meet your needs. This is a project that adapted our leadership and organizational change strategy for implementing autism spectrum disorder treatments in schools and community mental health settings. And as you can see, the important things that were utilized was this idea of the evidence-based intervention fit developed on a needs assessment and collaboration with users. So this idea of equity, inclusion, engaging with not only with developers, with implementation researchers, but also with end users is really important. Identifying specific aspects of outer contexts, influences of leadership and structure, and the inner context, their program or district factors, again, leadership, and then provider and client factors. And importantly, they have this idea of relationship with researchers. So using the EPIS structure and framework to think about how you would adapt and what determinants may be most important, and then what's going to occur in the implementation process. So really thinking about the preparation, implementation, sustainment phases in this project, and what occurs at the agency or district recruitment, when providers receive training, and after the research team is no longer actively supporting the intervention. And then thinking about these influences in the outer and inner contexts, and in terms of the intervention or purveyor characteristics. So again, an adaptation of EPIS, and so you don't need to use everything. There's also recent work in the idea of equity and power differentials in implementation. And Megan Stanton, Samara Ali, and their colleagues really did a very thoughtful piece on thinking about types of power and how those are engaged in exploration, preparation, implementation, and sustainment phases. So which way, power can be utilized, power can be shared, and with recommendations on more equity in the implementation process through discursive power, through epistemic power, the ability to assert one's knowledge. So, integral to a collective set of beliefs or truth. So again, whose knowledge is valued in problem conceptualization and intervention, innovation, and why? And do we have equity in this process? Do we have an inclusive approach? How is the health problem itself to be addressed? And do we have perspectives of the relevant people who are involved? And then material power, which is control over and distribution of critical resources. So what organizations, communities, and individuals are being invested in and why. And so they've done a nice job of outlining these issues across the phases. So it's a really nice kind of adaptation and extension of EPIS that takes into account those issues of equity. And they have some nice graphics in the article as well that can be useful. I mentioned this issue of policy. One of our grants that I'm working on with Erica Crable, the lead on this article, led to really thinking about where policy fits within EPIS. And so Dr. Crable led this adaptation of EPIS to be used for thinking about studies where policy is really one of the major issues that you would be looking at, and really identified this idea of big P policies, which would be live in the outer context. So these could be larger service environments, it could be a federal or countrywide policy, or it could be a district or a county or province or region policy, but it's kind of the larger policy. And then the little p policy. So what are organizational clinic level policies or policies within a given setting where you're actually implementing? So things to consider here, adaptations of political support, stigma, workforce capacity, local service environment, competing priorities. But again, this idea of cross-context alignment and what's the policy transfer, what's the bridging factor or bridging factors that link how well a big P policy can impact care within an organization or clinic context. So again, another advancement of EPIS around policy, and these are very recent. So this was a 2022 article, and we're actively working in this area. And Dr. Crable's whole research program is understanding policy in dissemination implementation science. This is an example of adaptation for a specific project funded by our National Institute on Drug Abuse that's looking at a natural experiment implementing adolescent community reinforcement approach to address adolescent substance use. And Dr. Alex Dopp at the RAND Corporation is the PI of this, comparing two federal financing strategies on treatment penetration and sustainment. And this is looking at grants that were made to individual organizations to implement the adolescent community reinforcement approach, compared to grants that were made to states in the United States, who then distributed funds to organizations. And so you can see in the inner context here, that's one of the funding strategies, the organization-focused grants. In the outer context, the other was the state-focused grants, and looking at state-level infrastructure, delivery and supervision, what's going on in the implementation phase in terms of penetration or reach at the clinician level and the client level, and then how well these were sustained post-funding, so after the federal funding ended. So this is another use of EPIS adapted for a specific project. And so you can get creative in how you think about inner context, outer context, and what phases. So in this project, implementation and sustainment phases are being used. Other more formative research might focus more on the exploration and preparation phases, for example. And so I want to go through some examples of EPIS studies before we finish up here. And this first one is our colleagues, Jonathan Pirtle and Nicole Stadnick, Dr. Pirtle at New York University and Dr. Stadnick here at UC San Diego. Wanted to look at the impact of what they call earmarked taxes. And these are taxes that are identified for a specific purpose. In this case, looking at earmarked taxes for mental health services, because, excuse me, some states in the US have done just that. So for example, in California, there was a voter measure that was approved to tax income over $1 million a year at 1%, and those funds would be used for mental health services. So that's just one example of earmarked taxes. And some states have done things in different ways. So for example, adding a small sales tax to be used for behavioral health services and things like that. And so for this project, there's a description of using the EPIS framework combined with the implementation strategy typology by Lehman et al. And as you can see here in the figure, they've identified the constructs believed to be important for this particular research question, right? So looking at outer context determinants, readiness of service environment to implement EBPs with tax dollars, and perceptions of demand as well among population eligible. And then inner context determinants, the climate within organizations' use of research evidence to make decisions about tax dollars and professional characteristics. Bridging factors, bridging determinants, collaboration across outer and inner context. And the innovation in this case is the tax, right? Perceptions of alignment between the tax design and how it's actually spent, how it's actually utilized. So when we talk about an evidence-based intervention, that can also be a policy. It can be a specific practice, it could be a treatment. So the idea of the innovation or thing that's being implemented is broad and flexible. And also really critical to any project that uses any framework is how are you going to measure those specific determinants. And so Dr. Pirtle and colleagues did a nice job of thinking about, inner context determinants, implementation climate, use of research evidence, professional characteristics, and was very clear about the subdomains within inner context that were important for this particular project and example items in the surveys that are being used. Same with outer context determinants. The subdomain clearly identified and how it's going to be measured. Bridging and innovation determinants, again, clearly identified subdomains and example questions. And then acceptability and feasibility and types of implementation strategies, and identified the subdomains again and what the specific measures are. And you can see there's a reference for each of these. So there's a specific measure for each of these constructs as you go forward. So that measurement is really important as you're thinking about your project and linking it to your implementation framework and the specific determinants that you've identified. I think one of the most comprehensive uses of EPIS is an example from the JJ Trials Juvenile Justice System study with the goal of linking adolescents who are involved with the justice system who need behavioral health care, and in particular alcohol drug treatment care with behavioral health. And that was the goal of this project. And so, as I said, this was a large project. There were 6 centers funded by the National Institute on Drug Abuse, 36 sites, and a collaboration between juvenile justice, community-based health organizations, and researchers. And this is a comparative effectiveness of implementation strategies with the core implementation strategies, including a needs assessment, data feedback, behavioral health training, and goal achievement training. And then an enhanced strategy, including local change teams, facilitators, ongoing support, data-driven decision-making, and facilitator training that's centralized, monthly facilitated learning circle and fidelity monitoring. So all sites got the core, and then half the sites were randomized to also have the enhanced strategy. And this was a stepwise design where sites were randomized to strategy and to when they would start, one of 3 start dates in the process. So, to frame this within EPIS, it was really helpful for the team in this large initiative to think about the core intervention bundle and when in the implementation process different activities occurred. So you could see in the core intervention bundle, some of these activities were in exploration phase, some in preparation and implementation. And then for the enhanced intervention, so of course, this group got everything that was in the core, but then in the preparation and implementation phases, added the use of data-driven decision-making and developing action plans, and then ongoing progress monitoring and assisting the sites and facilitation of local change teams across. So, EPIS was useful in really laying out to collaborators, to the funders, what's going to happen when in this process and why it's going to happen. And also, when we think about EPIS, we often get the question of how do we know when we're going from one phase to another phase? And so in this project, there were specific criteria for how we decide when we move from exploration phase to preparation to implementation and to sustainment. So for example, when the site selected their individual goal, then we moved from exploration to preparation phase. When the site agreed on their action plan, like what are we going to do next, they moved from preparation to implementation. And when data indicated that they've achieved their goal, they're moving from implementation to sustainment. And this was framed within it's called the SIC, the stages of implementation completion, had these specific benchmarks laid out for what was accomplished and what that meant in terms of moving from phase to phase. And our colleagues, Dylan Wong and Lisa Saldana, have been doing some nice work in thinking about the stages of implementation completion, which is a validated measure that you can use, helps tell us when we're moving through the EPIS phases. So really mapping the SIC onto EPIS phases, which can be really useful to track progress in a project, or if you're developing a grant application, you can think about how that can be used to help move things forward. But EPIS also can be used as a measurement framework. So thinking about what is measured at what time points in the implementation process. And I know that our group has to think about this and think through this in all of our projects. So what are we assessing at exploration phase? Do we need to reassess? So for example, if we're looking at organizational readiness, would we look at that just in exploration, or would it be a predictor of uptake or implementation at other phases? Or do we want to know at the end how organizational readiness might have changed over time? In JJ Trials project, looking at client recidivism at each time point, the staff value and use of practices, was the implementation process changing value and use of practices related to the implementation strategies, for example. So it can be really useful that way. And you can get more fine-grained about the primary questions in a project, your exploratory questions, and your mechanisms, your mediators and moderators, and when you might expect those to be important. So for mediators and moderators, the theory in this project was that they would mediate the transition from implementation to sustainment. So they were measured at baseline and at the latter part of the implementation phase. So EPIS can be really useful in laying out that measurement process. And in some of our discussions, I was sitting at one meeting next to a service health system leader who said, EPIS looks very linear, but we really think about these things as being in a cycle. And so I drew this on a little piece of paper and passed it over. And I said, you mean something like this? And they said, yeah, I think that's more what we had in mind. So we worked with the team to think about how EPIS and moving through these phases can be a cyclical process that you come and revisit things. And of course, our clients, our patients, consumers are at the center of this process. We want everything to support addressing the health problems or health issues. And so we came up with what we call the EPIS wheel, which was published in this publication in 2017. And it was sort of put into the model that we think, in exploration, we're thinking about all those issues and addressing what we think we need to determine. But once we get into preparation and implementation phase, we may be learning something when we start implementation that we say, oh, well, maybe we want to measure this other process or new process. Are there emergent things that we need to address or adapt? And if you'll remember back, I mentioned this idea of adaptation. And so if adaptation happens, we may need to kind of revisit an earlier phase to think about how we change things moving forward, or at least how we document the adaptation and how it might affect outcomes. And, I will say that the, core plus enhanced condition was more effective in engaging youth in effective treatment than the control condition in this study, and that was just published last year. EPIS also has been adapted in a number of different settings. This is an example of using EPIS for one of our scale-up strategies called the Interagency Collaborative Team Model to address trauma, mental health, and employment in adolescents. This is our colleague, Teresa Betancourt, who leads a program on youth affected by adversity at Boston College. And the idea here was to use EPIS exploration and preparation phases to set up for implementation of proactive problem solving and conceptualization and initial development, and adapting the scale-up strategy for Sierra Leone and then test it in the implementation phase. And so some of the language was changed. Instead of outer context, outer circle, inner circle, that was made more sense to our partners and Teresa's partners in Sierra Leone. And then identifying the specific EPIS determinants in the outer circle, inner circle across phases. So there's ways to do that and to represent that. And then to think about what are the activities around implementation across the EPIS phases. So there's a way to lay that out. And this idea of the implementation resource team, we've used in a number of different projects in Kenya, in Sierra Leone, in other settings, in Nigeria, to be more inclusive and equitable about who's involved, whose input is important, and whose voice should be part of this process. We don't want to exclude, and we don't want to make decisions based on my perception as a researcher, because I don't know the context as well as someone living in that setting. So that inclusivity is really important in EPIS as well. So I think, in applying EPIS in your setting, really thinking about, the different phases, what's important in the different phases in your given setting is going to be really important. And even in exploration phase, again, we'll say begin with sustainment in mind. It's just critical that we're thinking long-term about how we're going to sustain. We don't want to come in, test something, and go away. We really want to improve quality of life, improve health, And how do we do that? Well, by sustaining effective practices. So in exploration, that partner engagement is really important in preparation. Hopefully use your data gathered in exploration to identify needs across outer and inner contexts and how you're going to address those barriers and facilitators. And again, in implementation, use collaborative process to address emergent issues. So for example, in one of my projects that was a statewide implementation in the US, we would bring clinical staff, organizational executives, system level people together. Every year, we would look at qualitative and quantitative data, people's experience. We would talk about people's experiences and think about what are the emergent issues and are there things we want to assess going forward. So it's a really, implementation is a very active process, right? It's not something we're doing to someone, we're doing it together with our collaborators. And then for sustainment, really thinking about the need for how do we adapt for sustainment as well. And I don't think I'll belabor the rest of these, but I think this idea of those bridging factors across the phases is really important as we go. So I think, for all of the frameworks that we're talking about this week and beyond, well integrated use of the models, theories, and frameworks increases the likelihood of success for your grant application and for your project. There's no one right model, and selection of the model should be guided by your research questions. Adaptation of models should be done carefully for local context or issues, but it's going to be necessary. And operationalize the models well and throughout with pragmatic measures and approaches. Generally, mixed methods are needed, both qualitative and quantitative, and think how they can be used and integrated. And be clear about why you're using a specific framework, but then why you're focusing on specific aspects of the framework or frameworks that you're using. And you can use multiple models. So for example, in our current U01 in Nigeria, we've combined EPIS with the REAIM. But you can combine EPIS with the implementation outcomes framework or, et cetera. So there are ways to really integrate those. And it's just important to have a good rationale for why you're integrating multiple frameworks and explain that to reviewers if you're writing a grant, and also for your partners and collaborators to understand and have input in that as well. So with that, I think I'll stop and I hope we have time for some questions.
Thank you so much, Greg. Right now, there are no questions on the chat.
Okay.
So I think we can now go ahead and make his presentation. So, Dr. Gushola, we're ready for you.
Yeah, thank you, Greg, for that beautiful presentation. And you've set the tone, and I want to use this opportunity to thank NISA for creating this platform, for sharing our experience and for learning. So today I'll be sharing our experience of how we use EPIS in implementation, not in research really. And I will try to show how we use those phases, the inner context, the outer context, the bridging factors, and what we've done so far. So our project is, sorry, my screen is not moving. Let me share again because my network may not be too good. Okay.
Yeah, we can see your slide.
Is it moving from your end?
No, we're still at your title.
Yeah, it's not moving from here. So I'm coming. Let me reshare. Yes, is the network not moving?
If that doesn't work, you could email it to me or Tonya, and we could run the slides for you.
Okay, let me try to do something. Okay, let me share this. Okay. Okay, so cervical cancer accounts for about 21.7% of all cancer deaths in sub-Saharan Africa, with a high case fatality of about 68% and 3% survival rates at 5 years post-diagnosis. And we know that the major drivers of cervical cancer in sub-Saharan Africa is HIV and the high prevalence of the high-risk HPV. And we also know that the HIV positive women are at higher risk than non-HIV positive women. The risk could be as high as 6 times. Though the WHO is talking about HPV DNA testing, the Federal Ministry of Health in Nigeria, for now, due to other issues, have adopted cervical cancer screening using visual inspection with acetic acid and glucosiodine with electrotherapy and thermal ablation for precancerous lesion, at least for women living with HIV. But we also know that VIA is very subjective. There are tendency of overdiagnosis because VIA has a very low positive predictive value. So, in order for us to improve this, we thought of that we need to do something about it. When we began the implementation of cervical cancer screening among HIV, we noticed that in the first month of that implementation, whereby people were trained, nurses were trained, doctors at lower level health facilities, and we noticed that only 25.7% of people that were initially classified as VIA positive and eligible for thermal ablation were actually positive. So that means there were a lot of false positive. And literature have shown this. We felt that we need to address this issue because now, because of the resource limited setting we have, VIA seems to be the option we have, though we are moving towards HPV DNA testing, but it's not that common here in Nigeria. So we use the EPIS framework to think through, to say, how can we go about this? And like Greg said, the EPIS framework has the exploration. The exploration talks about finding the appropriate evidence-based practice to address a problem. The preparation is where the planning begins. So we look at potential barriers, we look at facilitators, and we try to also maximize the facilitators and minimize the potential barriers. Then we implement activities and strategies. And of course, under sustainment, our focus is to promote the use of the evidence-based practice. So on the exploratory phase, the first thing we did was to identify the key stakeholders. When Greg was talking, he was talking about the outer context, the inner context. Those are very clear. So for this, our outer context, we are the policymakers, the Ministry of Health, because they drive the policy. We also look at the healthcare providers at primary, secondary, and tertiary. So this will fall into the inner context because they are the ones that will provide the services. We also look at the focus, the patient, women living with HIV, which is our focus. And because Nigerian HIV program is heavily funded, we also look at the payers, PEPFAR, USAID, CDC, and looking at that EPIS framework, they are the bridging factor, so trying to look at both the outer and the inner context to bridge everything because they provide some kind of support financially and materially and even technically. So under the exploratory phase, we had stakeholder discussion forum with these key stakeholders, government officials, healthcare providers, on how to reduce the risk of misdiagnosis associated with VIA screening, especially among lower cadre of health professionals. We had key in-depth interview with stakeholders, focusing on the program needs, looking at readiness for service delivery, looking at what existing strategies exist. Well, the key interview reveals key things about barriers to effective VIA-driven screening and treatment program, such as inadequate skills of healthcare workers, insufficient equipment and consumables to support cervical cancer screening, and of course, the issue of subjectivity of VIA screening tests. And like we heard earlier from Greg, that even at the point of exploratory phase, we need to begin to think about sustainment. So any strategy that we'll develop here, how will it be sustained? How will it be adopted? And as you see, that we came up with an app called Aviva. So key findings from this exploratory phase is one, that there is need for us to do a site assessment and service readiness. Look at these facilities, look at the structures, what are the mechanisms, what are the infrastructure available in terms of in many domains. Then there's also a need to develop a real-time app that could share high quality cervical images with experienced reviewers to make an instant decision. Now, what that is saying that, what people said that, okay, if we have a problem mostly at the lower level, can we develop a system whereby someone at the higher level can review? And this talks about into the inter-organizational environment. And if you know, in Nigeria, our health system is divided into three. We have the primary, secondary, and the tertiary. So we look at this inter-organizational environment. How can this work? So those are secondary and tertiary. Can we get people who have more experience, who can look at this image and provide opinion while the patient is on the bed, in line with the WHO see and treatment? Of course, issues about ongoing mentoring and supportive supervision, and of course, the involvement of the Ministry of Health, academic institutions, funders, and other partners came up. So that was the exploratory phase. So looking at the preparatory phase here is beginning to look at strategies. What strategies did we develop, or did people come about? And we tried to align these strategies with the ERIC strategies. The ERIC is the expert recommendation for implementation change, whereby experts look at implementation strategies and try to name them, have a common nomenclature so that people around the world will speak like the same language, so to speak. So one of the things strategies came about is, one, they need to assess for readiness and identify barriers and facilitators. Issues about site selection and engagement, identify and train healthcare workers, which the ERIC, so they talk about conduct ongoing training. That's the word used in the ERIC. Then change physical structures and equipment, and of course, focus to develop an app, which is the innovation we are focusing on. So we did this, we used the WHO SARA tool, the Service Availability and Readiness Assessment tool, and we assess various domains, human resources, adherence to protocol, equipment, commodity, diagnostics, infrastructure, and other factors. And these sites were scored, we did a domain weighted average, and that also guides us to see that which sites are ready, really, so that we'll do this in phases. We won't just go to all areas because of this problem that we noticed. Then for training, identify key healthcare workers that will benefit from training. We had criteria for this. Then looking at changing the physical structure and equipment, we are talking about cervical cancer screening. Okay, from the site assessment, what are the commodities? What are the consumables? What are the physical structures, the screening room that these facilities will require? And of course, the innovation, which is the Aviva app. The Aviva is the APIN visual VIA app. So the app, key things we are looking at is that we need to develop a hub that can do a real-time sharing of patient data and images of the stain cervix. We also need to have an hub that an expert reviewer, expert gynecologist, oncologist can quickly review and provide feedback to the patient. And that this VIA should be, this Aviva should also help to improve the diagnosis precision or accuracy. So these are the strategies that was developed. So at the point of implementation, sites were implemented in phases. Issues about monitoring and evaluation, on-site mentorship, in which we have people who are trained, technical staffs, expert gynecologists. We also have reporting tools to guide so that we can monitor. And we also have tools to measure how well is the Aviva Hub performing, because already we said when they were doing it, they were high false positive. So how can we measure what is the concordance rate between the case finders, the healthcare workers, and the expert reviewers? So tools were developed for that. And during the implementation phase, it's not just a one-off phase, because as we implement, you begin to see some barriers, you begin to see some facilitators, you begin to see some strategies. Hello, you lost me, I guess.
Yes, we lost you for like 2 minutes, and your slide is down. So you can put it up and continue.
Okay, can you see me now? Can you see the slide?
Yes, yes.
Did you hear this slide? Or I should go back?
You can no, start again from here.
Okay. I guess the network is really bad there.
Yeah, it's down. Your slides are down again. Okay. Yeah, thank you.
Yeah, it's not moving now, right now. Let me try to make it move. Come in. Where I am.
Yeah, okay. We're seeing the background.
Okay.
Yeah.
Is it okay now?
Yes, okay. Thank you.
Yeah, so I was saying that during the implementation phase, it's just not a one-off thing. Like Greg said, we'll begin to look at things that we can refine, strategies that we can refine, or in this case, the innovation that we can refine, things that we can improve on. So the Aviva Hub underwent many revisions. One of the key revisions is that it's not just sending the pictures. There's need for us to have a notification service so that the reviewers will know that they have a picture to review. And also the case finders, the healthcare workers in the facility will will know that, okay, they've reviewed their image, they can check their phone and act on it. Then with time too, that since they are reviewing this picture, it's not just providing opinion about whether this is VIA positive, VIA negative, or this is something else, that they can also provide some comments. So comment section was created on the app, and we allowed some analytics to happen. So these are the phases in which the site went from 19 to 61 to 86 sites. And currently about 29,000 women have been screened, with 1,609 that are VIA positive, giving us a VIA positivity rate of about 5.5%. So this is a picture of the hub. This is what happens. So this is just a demonstration. So the case finder here, the health worker, takes the picture and upload on this app, send it to the reviewer, and the reviewer makes a diagnosis. So we just covered some information here so that we won't see and talks about those things. So how has this fared since we've started? So like I said, our focus is to improve diagnostic precision. We have about 9 expert reviewers. Currently, we have over 4,000 images uploaded, and our reviewers rate is about 96.8%. So that means for the pictures that were sent to reviewer, about almost close to 97% of those pictures were reviewed. And we have about 150 case finders, health workers, screening women living with HIV for cervical cancer. In terms of the concordance rates, before Aviva was introduced and to this current moment, we've noticed a 16% increase in the VIA positivity and negativity concordance rates. So that shows that Aviva has improved the concordance of, has improved the diagnosis accuracy or precision by 16%. well, like I said, this is still an ongoing implementation, and we are working on that. Now, looking at the sustainment aspect, like we said, from beginning, we involve the government, we involve the funders, we involve those in academic, and we also involve the Nigerian Implementation Science Alliance, on which platform we are presenting this experience today, because we are looking at the use, not just beyond our program to other programs, and that we're also thinking about how people will adopt this in their own setting to use, because if finally, as we go about this, saying that this is improving diagnostic precision, is reducing misdiagnosis, that it could be a hub that should be used in areas whereby there are limited resources before HPV and other tests becomes readily available. Our future consideration is that, which we are working on, is to even look at this app, compare it with the gold standard, which is biopsy. So compare the concordance rate, so that if it tallies, it also gives us more evidence to say that this app is really solving a great problem in resource-limited setting. These are the references for these few slides, and I say thank you.
Thank you so much, Dr. Ogunshola. Thank you. So we have some questions for Greg and for yourself. And I'll start with the first question is for Greg. It says, please, what are the core elements of effective implementation strategies?
Okay, so first I want to thank Dr. Ogunshola for that really nice example of using EPIS in an actual scale-up. So the core elements of implementation strategies is a good question. And that, of course, depends on the implementation strategy. So I think in the, it might be helpful to pull up one of these slides that I had. Okay. I'm going to share my screen again to answer this question. Okay, so in this one, you can see there are core aspects of the intervention and then the enhanced intervention. So that gets at the characteristics of the intervention itself. However, the core elements of any strategy is something that really needs to be identified during the preparation phase. So when you're thinking about strategies, something simple like, excuse me, audit and feedback, for example. I think the core, excuse me, take a drink. The core elements of audit and feedback is, are you collecting the data for the audit effectively? Is it reliable? And is it valid? For the feedback portion. So to me, those would be the core elements of the audit piece. For the feedback piece, is the feedback prepared in a way that's easily understandable? So for example, if the feedback is to a clinician, and the clinician look at a feedback report and understand what it means and how to use it, right? So those would be the core elements of that particular implementation strategy. But this is such a great question because for each strategy, there's going to be the need to go in and determine how you would assess fidelity to the strategy. And so going through that process, and we're doing that right now with our large UO1 here in Nigeria, how do we understand fidelity to the implementation strategy? In order to do that, you have to identify those core elements determine how you're going to measure them, and make sure that that measurement happens. Another example is, I think, our leadership and organizational change strategy has multiple components. And the first is a leadership training that we do. And so did we deliver elements of the training? So we address transformational leadership. So did we present information on transformational leadership effectively? Then there's a section on implementation leadership. Did we cover that curriculum appropriately? And we can document that because we video record the actual trainings, so we can go back and look at that. In terms of teaching about the importance of implementation climate, did we cover the domains of implementation climate in our training? So we can go back and say, yes, this was covered. Yes, this was covered. And so there's sort of that yes, no fidelity, but then there's also the quality with which it was delivered. So that notion of competence in the presenters or the trainers might be something else we want to know about. And again, we consider those core elements of that particular strategy, and so we want to be sure that we can assess those.
Okay, so yeah. So the second question says, considering all the components of the EPIS framework, how were you able to navigate the barriers identified in carrying out the interventions over the years?
Yeah, another great question. So that's from Confidence. Great to hear from you. It's like I said, when I presented the EPIS framework first, there's many constructs, and that's true for almost every framework. I think that was evident in REAIM, evident in CFR. We need to determine and identify for our particular project in a particular setting. How do we, we have to go in and say which of those constructs are important. Not all of them will be. So it's not a matter of, using everything in the model. It's a matter of saying for our particular project, what are the important determinants? What are the important barriers and facilitators in this context at this time? And then I think in the examples of the adapted frameworks that I showed, you saw that they were selected from the larger EPIS framework or adapted from the larger EPIS framework. So it's really important to kind of think through the frameworks that you're using and then narrow down to the determinants that you think are most important.
Okay, the next question says, are there specific methodologies for each phases? For instance, in the exploration phase, can one go beyond the systematic review? Can we use mixed methods across the phases?
Yeah, so I love this question because I am a big supporter of using mixed methods. And yeah, it's not enough for literature review. And in fact, we developed an interview guide for the exploration phase that has assessments at the system level, at the organizational level, at the provider level, and at the patient or consumer level. So, questions to think through at each of those levels, how to do that. We originally developed that as a quantitative measure, but quickly came to see that it was more useful as an interview guide to guide us through the process of engaging with our partners at different levels. And now we often use that with some quantitative measures to understand leadership, to understand climate, those types of things, or even to understand organizational readiness. And so triangulation of your qualitative and quantitative methods is really useful, and we can learn a lot by integrating those methods.
Okay, so the next question says, sometimes I hear it said that implementation research is not sufficiently rigorous, but there often is not enough time or skills or resources to meet high standards of rigor expected in conventional research. What should be done in such situations, as I'm from Nepal, a low middle income country where we have many limitations?
Yeah, so it's a really good question. And I think part of the disconnect is often from intervention researchers that are thinking, a very narrow efficacy clinical trial with a very select sample compared to implementation research. And I love this question because it really does recognize, one, that implementation research is, I don't know if I want to say messy, but complicated. And that's where using a framework appropriately and narrowing down to those specific determinants within a framework and being able to say why you're selecting those, how your strategy that you develop or selected addresses those determinants, being very clear about that. And so I think, one example is, I'm doing work in Kenya with Susan Meffert from UC San Francisco, and they have a hybrid type 1 study, and that's going to be talked about tomorrow, hybrid designs, but that's essentially where you're looking at effectiveness while observing implementation characteristics. And so they're testing effectiveness of two depression treatments, fluoxetine alone, interpersonal therapy alone, or those two combined, but engaging with also the Federal Ministry of Health, federal politicians, local county stakeholders, hospital stakeholders and providers. And I mentioned this implementation resource team earlier to think through these questions of, which barriers may be important and how they're going to address those in a larger scale-up study once this effectiveness trial is completed. So it can be done in these settings, but of course, external funding is often needed, and partnering with a U.S. institution or seeking funding through the U.S. National Institutes of Health can be really effective. And our work, for example, with University of Nigeria and our colleagues at UNN, we're working on building research infrastructure while also conducting studies together to help build capacity. And there are more and more calls that we're seeing, requests for proposals and program announcements supporting implementation research in low and middle income countries. So those are coming from the U.S. National Institutes of Health. And so there are opportunities to apply for and hopefully obtain that funding to do this kind of work. And so partnering with U.S. institution, partnering with experienced implementation scientists can be really helpful. And I think if you're able to come to the Nigeria Implementation Science Alliance meeting, we have a lot of opportunity there for talking through these issues, for networking, and for creating relationships that can help facilitate that.
Thank you. The last question says, what can we say are the differences between core intervention bundle and the enhanced intervention bundle?
Yeah, thank you for that question. So again, for any given study, the examples that I gave were for that particular trial, large-scale trial in the United States, where there was a set of core strategies, and we were very clear about what those were. And then the enhanced, we were also very clear about that. And let me just pull up that slide again real quickly. So yeah, so if let me make that bigger. So you can see here, we've clearly identified what the core intervention and strategies are: education and training, and then quality improvement. And then within those, there are specific activities. So for education and training, there's training in behavioral health and skills-based data-driven decision-making. So that's part of the education and training. For the quality improvement strategies, doing a needs assessment, creating a site feedback report, working together on goal selection and data-driven decision-making templates. So those were those strategies. And then, so we're very clear what's in the core bundle, and then the enhanced further assistance in developing action plans and progress monitoring, and then developing their local change teams. So really creating a team within each site to really support that ongoing implementation and sustainment. So again, you have a lot of latitude, you have a lot of discretion in how, for a particular project, what you want to be core strategies across different conditions and what you want to be enhanced. So, what we could do, for example, in our leadership and organizational change, we could make leadership training the core strategy, but we could have climate development teams for the enhanced. So one group would get just leadership training, another group would get leadership training and a climate development team, for example. So it's really a matter of thinking through that with your colleagues, and this is where an implementation resource team can be really helpful in say what's important in this setting, what's important in this clinic, or what's important in this congregation in terms of really core strategies that we would need. And if we could do, if we had the luxury of doing an enhanced, what would that be? What would be the plus that we could add? So it's a great question, and yeah, I think it's really fun to think through those issues.
Thank you, Greg. So there's one last question from Prajita that says, which model complements EPIS the best when utilizing multiple models simultaneously?
Yeah, there's so many of these questions that are, it depends. We've used EPIS with REAIM, using EPIS as our conceptual model and REAIM as our evaluation framework. Another is Enola Proctor's, Enola, who presented on Monday, implementation outcomes framework, which she described in her talk, that really focuses on what are the important implementation outcomes, service outcomes, and clinical outcomes that we might select to use. So for me, those are good. And then thinking about studies in policy, thinking about more policy, things that come out of policy or political research or public administration research, there may be tools and approaches and frameworks. We do have a new center funded by our National Institute on Mental Health on team effectiveness research, for example. So we're bringing in conceptual models from team effectiveness to think about how implementation teams can be more effective in implementing evidence-based practices. And so some of the theories in team effectiveness have to do with improving team functioning, shared mental models, being on the same page, team cohesion. So we bring in theories from organizational research into EPIS to help guide a specific project where we're doing team effectiveness in implementation. So again, I think thinking about those outcome frameworks is really helpful, and evaluative frameworks, but also conceptual models from other, what we might think of as relatively unrelated approaches. So yeah, so it's pretty wide open as far as how you integrate them. But again, in a grant proposal, the main thing is that you have been very clear about why you selected those frameworks and how you're using them together.
Yeah, thank you so much, Greg. There's no more question in the Q&A. So I'd like to ask the director for the Center for Translation and Implementation Research to tell us one or two things about the upcoming NISA conference. Prof, over to you.
Thank you so much. Thank you, everyone. This has been a very interesting thing and opportunity for all of us, and I'm so grateful to Greg. One thing I just want everyone to know, Greg is going to be at the at the Nigerian Implementation Science Conference in August. So if you want to take a chance to meet him in person, please remember to register for the meeting. The deadline is coming. Abstract can be submitted to June 30th. Early registration ends this month. So if you do want to come, take advantage of the low cost. We have kept the cost low. It was even lower than the cost we had in 2015 when we started. And the reason we did that was from support from the IPs, and we're very grateful from implementing partners, PEFA implementing partners in Nigeria that have supported NISA in a way to allow for this cost to remain the same as it was in 2015, even at the same current exchange rate in 2015. The cost has remained as $100 for Nigeria. We left that exchange rate of what it was in 2015, just for you to be able to come, and that is due to support from those implementation partners. So I want to say thank you to them again. Greg has done something that is remarkable. He has been to Nigeria multiple times to NISA, and one thing that he has done was really to work with groups like ours, and many others to develop grants and be able to write those things and be able to mentor people to use this type of approach, including EPIs, but not limited to EPIs. In one of the grants, as you saw, we did EPIs and REM, combining them to do things. So if you do have a project that you are using EPIs and you need mentoring to it, please reach out to us. Again, you have to be a NISA member to be able to get those things, and that's one of your benefits of being a NISA member. So when you register for those conferences, consider becoming a NISA member, and that will give you access to all the people that we have here, but also to teams that are in Nigeria that can also be mentored for you. So thank you all so much, and we look forward to you joining us tomorrow for the last section of this week, and then we will be concluding this week. I hope this has been to you as useful as it has been to me. Thank you so much. Bye.
Thank you so much, Prof. Thank you, everyone. And see you tomorrow, same time, 4 p.m. West African time. And take care. Bye-bye.